Hi, folks. It's an honor to be here with all of you today. I'm Dr. Adrian Arcachea, and I'm the Director of Social Emergency Medicine for our emergency department. I'm passionate about collaborating with our local central Brooklyn community, as well as our attendings, our residents, and fellows to address the social determinants of health for our global domestic patients. And today I have the honor of introducing our next three speakers. First, I'd like to introduce Ms. Camila Figueroa, who is the lead senior program coordinator for community engagement and health equity research at the Arthur Ashe Institute for Urban Health. There, she oversees the Communities Together for Health Equity Network, which includes over 70 community-based organizations focused on social determinants of health. With a master's in psychology and a focus on global mental health, her work is driven by a deep passion for improving health outcomes for underserved groups, including immigrants, racial and ethnic minorities, as well as low-income individuals. Next, I'd like to introduce Mr. Umberto Brown, who is the Director of Health Disparities Initiatives at SUNY Downstate Medical Center, where he works closely with the Arthur Ashe Institute for Urban Health on community-based participatory research. With a background in psychiatric care and cultural sensitivity training, Mr. Brown has dedicated his career to addressing health disparities, particularly through initiatives like prostate cancer education and with African American and Caribbean barbers, and advocating for greater diversity in the healthcare professions. And then finally, it is my honor to introduce student Dr. Sabrina Muana, who is a fourth-year medical student at Downstate Health Sciences University and is deeply committed to human rights and addressing social determinants of health, a passion rooted in her own immigrant family's experiences with systemic challenges. She currently serves as the co-director of the SUNY Downstate Asylum Clinic that provides compassionate care to underserved populations and is part of the Health Equity and Leadership Pathway, aspiring to become a physician who champions equitable and culturally competent care. So thank you, everyone.
Thank you, Dr. Adrian, and good morning, everyone. So thank you for extending the invitation, Dr. Smith, for us to be in this space. We're very excited to share this space with everyone in this room, many of which we've partnered with across the years. And we are going to talk today about community engagement to advance immigrant health. So this is our proposed agenda for today. Umberto will be talking about who we are, what we do, and why we do what we do. We're going to talk about trust and the history of distrust among immigrant communities, and the importance of community partnerships in addressing immigrant health as well as underserved communities' health. And today we're going to also share some best practices, some interventions that we've co-developed with partners like the Brooklyn Free Clinic, like the Star Clinic, as well as other community partnerships. We're going to share some lessons learned and future directions, and then the Q&A will be at noon. So write down your questions. If you have any question, we'll join later. So I'll pass it to Umberto Brown.
It's a pleasure to be here. Well, I want to just start to focus a little on the Arthur Ashe Institute, why we're here, what we do. And in our mission statement, you can get a good sense of what we're trying to do or what we continue to do and committed to do to transform the way health is provided and our conception of what healthcare is for our communities. Arthur Ashe, as most of you probably know, was a great and famous sport person, athlete, tennis champ. But one of the most important things of Arthur, that he was a social justice activist. So Arthur left a legacy and wanted his name to stay in an institution that will make a difference, because his experience as he received healthcare during his illness is that he noticed that no matter how famous he was, what group he represent, he still have some great limitation in how he was treated, who treated him, and accessibility. So when you look at our mission, as we still say, is based on promoting equity through social justice and developing strategic partnership, innovative community-based health promotion, research program and preparation for three things that I think is a fundamental understanding the arthritis. Next slide. One, that the first thing we did is try to develop programs that correspond with where we saw the needs of our intervention based on the legacy of Arthur. One, community engagement and research. We understood, because some of the work that we do from communities and the multiplicity of immigrants in our area, that we need to engage communities directly from the ground, their version of life, their understanding of who they are, because as most of you know, work in this field, we have many stigmatized, distorted, ahistorical concept of the community that we serve. So one of the things we did was to connect with the communities, and the area where we connected with some sustainability for more than 30 years is the barbershop and the hairstyle salon. These are institutions that historically have served our community and where people built relationship and trusted each other, that they're a community that protect each other. The other thing we responded to was the disparities and the incredible gap that exists in the health profession. For those, most of you are involved in health, the health profession, you know that the numbers have not changed significantly in relation to the percentage of doctors, of people of color, gender-wise, in all the profession, from medicine to doctors to nursing to occupational health. So that's why we created the Health Science Academy in an attempt to start creating a pipeline to connect these young people, give them a vision, give them an experience that attract them to be part of this process of creating professionals that understand their community and makes a difference in how they treat them, what they propose for them, in many ways. The other issue of community engagement for us is, as we work with, our history is working with many institutions, hospitals, governmental structures, a lot of foundation, pharmaceutical companies, is the issue of defining community engagement, what it means. Because in many ways, community engagement for a lot of organizations is just a distribution of a leaflet or giving information about their products or promoting issues that is not linked to the community needs. It doesn't respond to what community understand, and it doesn't bring this community in as partners, as being giving them agency in addressing some of the things that they need. So with this slide you have in front of you, we think there's some fundamental and core principle. Trust is one of the significant one that we'll talk a little more about moving forward. Bidirectional communication, that we're not talking to people, but we're also listening and doing active listening and checking our biases as we speak to people. Being inclusive, culturally centered. And when I say culturally centered, again, understanding culture and the complexity of what culture represents. Sometimes people use culture in a stigmatized way, stigmatize individual, families, and they don't question the issue of what they call in culture as they address these community. Equitable finance, that's a big one in our community. They participate in many research, many activity, but they don't get the kind of support to sustain the work that they do. Multi-knowledge, again, explain itself, that there are multiple forms of knowledge, multiple way of seeing and feeling and understanding our surrounding and experiences that we have. Shared governance, how do we include these people in decision making? How do we bring them in assessing their view of what is the best way to develop a project, to implement it, that it has to be ongoing, is co-created. Again, that's very important for the community. You can't design things for a community which you don't understand nor include. So why our work, how do we define and what defines our work? Social determinant is a concept that, a process that I would say since 2008, the World Health Organization developed that major report showing that the social determinant of of health is what defines at the end the outcome of quality of life, where you live, how you live, what condition and accessibility of food, and all those factors that we already know. So one of the things that we learn and we work with community is what create the condition, those conditions this community live in, and what we call unhealthy stream, right? But that creates inequities. So when you look at this issue, what we try to do is understand both the policies, the practice, the condition that it creates, and some of the outcome. And if you look at what you have in front of you, you can see that bad policies create bad condition, and bad condition create bad outcome. So therefore, most of these things, I'm not going to go through all the details of it, you can see it. We see, okay, how you respond to unhealthy stream. How do you, from inequality and inequity, what do you do? So our model is to create, understand, to discuss the issue of how you create healthy stream to create equity, right? Because again, today, everybody uses terms. Equity is a very popular term. People use a lot of conception and terms. What it means, I know you get operationalized. How does it get applied? Is where we kind of go to the ground and work with community to do that. So in our work, we develop, for example, work with a lot of institutions to understand the impact of some of the policies that impact our community. If it's environmental, is how we deal during the COVID pandemic, what type of information, safety net, who do you go to inform the community? Do you include the community, right? And what we try to do when we work with a community is explain the kind of policies, the practice, and the possibility of different outcome. And that's what this healthy stream and unhealthy and healthy stream mean to us, is understanding the relationship, because a lot of time we see health disconnected from those social conditions. And we are happy that today, some of us who've been involved in this for a long time, and from Latin America and other places, we have understood for a long time that social determinant is what defines the quality of life. Is not only illness or disease, and addressing those things, is addressing the condition that created. And that's what this frame shows. I will pass it on to Camila to talk a little more about immigrants. I just want to say a few things. One, for those of us who've been doing this work at different level, I'm a faculty at Downstate, but I've been assigned in a partnership with Downstate, with AAIUH. I've been one of those people that work historically with the AAIUH Institute. So we connect both the issue of research, developing strategy for community, and informed by the community what they need. And there are a few things, I'm someone who do a lot of international work in Latin America and the Caribbean, but one of the things I want to call our attention is that when we define things that we say immigrants' health, I explained to some of the staff, when you're immigrants in the city and you come from Latin America, the Caribbean, Africa, as you come into this country, you live in places already of marginalized, underserved, discriminated community. The African-American community, the Caribbean community, the Latino community, El Barrio, or in the Bronx, you come in and you suffer the same consequences of structure. Then there, addition to that, the new things that you bring, different language or different, some of us who have been on the border with Mexico and the US, the trauma to go through there, what's happened to you. I'm from Panama, people coming from Darien, that you go from there to here, that process add to already a structural system that discriminate and create the outcome of inequities and unhealthy experiences. So one of the things I always say, immigrants' health doesn't have just a separate experience. It becomes part of the already group that are discriminated historically, and it add new factors that we have to understand and integrate to it. And to always, one of the things when I work with a lot of students is to understand that culture is a very complex concept, and you can use culture to discriminate, to stigmatize, or you can use culture as an open door to understand people with empathy and compassion and where they're coming from. If we have an understanding that health is a human right, it's not defined by citizenship, immigrant status, but the condition as a human, because we all should have access to care at the moment that we need it and where our life is at risk. Camila, you can go forward if you wish.
Thank you, Humberto, for the introduction, the framework. And I think this is relevant for us to understand when we are sharing with you some of the interventions that we've designed come from these lens of intervention, not only seeing the health outcomes, but also understanding the conditions that people are living in and what are the policies and practices in place that are shaping those conditions. So I think we can situate ourselves within the immigrant population, but also, as Humberto was saying, kind of like understanding the compound effect or the compounding effect that immigrant populations have when coming to this country, when coming to this city. It's a significant percentage. Many of us in this call may see ourselves in these data. And when immigrants arrive to this city, or even when they're coming to this country, the first thing that they may think of is where to go. And usually where people congregate is where there is already an element of trust. It's usually a family member, is usually someone they trust, knows. It may be church or any faith-based institution. People consider trust as a key element when getting access or connection to needed services and resources, not only in the realm of health, but also in the realm of social needs, of support. And that has been something that has been consistently reaffirmed by community members through our community listening sessions. Here we have one quote. Once someone got connected to someone they trusted, who was connected to that system, they had access to all of these resources that they weren't aware of. So we don't talk that much about trust as being a key element in health, in well-being, in quality of life, in how people get the services and resources they need. And we want to also acknowledge the history of distrust. There is some historical trauma of immigrant communities being often perceived as a global threat. Media representation, and I don't think we're talking about many years ago, but negative media portrayals amplify biases and fears, and that creates misinformation and fears that makes people, especially immigrant communities, in fear of being deported, of even seeking care, right? Sometimes when they access systems that may have the services and resources they need, they may be asked about their address, their phone numbers, how many people you live with. And they may think, well, I know it sounds like you may want to help me and you may have what I need. However, you may also hurt me because I live in a household with other immigrants, with others that might be undocumented and might be in fear of getting deported. So that's a reality we live in today, in a world full of fear, with misinformation, of stereotypes around immigrant communities. And there are within the healthcare system structural barriers to access services and resources, such as limited insurance, lack of transportation, and all of these creates a lot of skepticism about the system's commitment to actually address people's needs. There is also a workforce shortage. This is a big challenge for the healthcare system, especially also for the emergency department, which is usually receiving the emergency, right, that immigrant undocumented folks maybe experiences, and the strain on services leads to longer wait times, resulting in delays in access to necessary care. This is something that you may all experience yourself day in and day out. And there is an additional barrier that is what Humberto was talking about, and what our Health Science Academy at the Institute is trying to address, that is the lack of representation. in the workforce, which leads to a cultural disconnect and a lot of mistrust, making immigrant communities less likely to seek care. So with this in mind, understanding the history of distrust and understanding where people go to for information, the premise of the work that we do is the closer to a community you are, the closer you are to a solution. And here is when we really want to emphasize on the importance of community partnerships in community health, because they are the brokers of trust. This is the model of community engagement that we follow at the Institute, and it begins with building relationships, establishing trust and building strong relationships with the community being served by identifying and prioritizing the issues that matter most to them, not to funding streams, not to us, but to them. And we, of course, we have tools to assess mental health and social determinants of health needs, and also understand what are the barriers accessing services and resources. We make sure always when we're serving the community, because I believe that we are all tired of being surveyed and being asked the same questions all over again, and most of the times not knowing what this data is for, or what are they doing with my information. One of our principles is always reporting back to community, sharing findings that we will be sharing today with you, and providing education to understand the social determinants of health as structural issues, empowering communities also to be agents of change, to continue to advocate for their needs. Identifying and engaging stakeholders is important across this process, right? This is not an easy problem. It's a complex issue. It doesn't have a quick fix, and we need to ensure that there is collaboration among the different individuals that are probably joining this call as well, right? Providers, clinicians, policymakers, decision makers in collaborative endeavors to really influence change and truly transform the healthcare system that we have nowadays. And then always creating a flexible model that is flexible enough to include lessons learned, to enhance future research, to understand future advocacy initiatives, while also deepening these collaborative partners. So this is our model in action. The Institute is the lead agency of Communities Together for Health Equity, or CTHE. This is a partnership. It's a coalition with over 70 community-based organizations. And we've been truly involved, actively involved in shaping policies and practices such as DSRIP, the 1115 Medicaid waiver happening now. And part of our role is also assessing for social determinants of health, right? So in the past years, we've assessed over 1,500 individuals. The majority of them have participated in our educational workshops. At the bottom, you can see some of our community-based organizations partnerships across the city that have been included in these endeavors. So here is just a snapshot of who did we hear in 2022 with our SDOH assessment. And I think what's important to highlight here, more than the numbers, is that our process allows us to reach these population that does not reflect what research historically has been able to accomplish. We have a high percentage of folks self-identifying as male. Half of the population we worked with was born outside of the US, which can give us a proxy of the immigrant communities that we serve. 35% of them had a disability. We also have a big group of folks that self-identified as Asian, Black, African American. And to Humberto's point, when we talk about immigrants' health, it's not just like this separate clustered group, but what are the realities also of underserved and often marginalized populations, right? And here is top priority needs in terms of social determinants of health. And while this data itself it's not new probably for most of us, but its significance relies in validating the experience of communities, in reaffirming that these are areas that remain important and deserving of our continued attention. And I hope that we are all in agreement that health goes far beyond medical treatment and that social determinants of health are largely responsible for our health. So when hearing what people are doing, most participants listed that they themselves needed between 1 to 4 resources. So it's important to see this information from an intersectionality lens, right? It's not only food, it may be food, employment, and housing. And in regards to the mental health indicators, we have a huge percentage of folks reporting feeling depressed, down, or hopeless more than half of the days in the prior 2 weeks. Again, this is data from 2022, closer to pandemic times, and we know that the pandemic exacerbated also mental distress, especially among underserved communities. And something that I want to highlight here is the high percentage of individuals that wanted to be connected with needed services and resources. This is over 300 people from the sample that we're showcasing that at this moment. That's a lot of people. And some of the barriers to care that they experience are, one, difficulty understanding information about their health. I think that it doesn't matter if you have a PhD, a master's, a bachelor's, understanding your insurance, understanding how healthcare system works, it's extremely complicated. 21.6% of participants did not feel confident using the internet to make health decisions. And this is relevant because healthcare has been transitioning to providing digital care, right? Childcare is also a big barrier for individuals to access healthcare as well as transportation. So with this in mind, we wanted to share some of kind of like a snapshot of the population that the Institute serves, and now coming to understand best practices in addressing immigrants' health, right? Community-based organizations, non-traditional venues like barbershops, hair salons, churches. We're going to talk about some of the interventions that we've done in a minute. But as I was mentioning at the beginning, there are brokers of trust. They're essential because they provide that ground level insight and realities that inform our processes, right? So with community-based organizations, for example, this is our advisory board from the CTHE consortium. We've made sure that we consistently are influencing policies and practices that are the ones that are gonna shape the conditions that people are in and therefore the health outcomes, right? So DSRIP again and the New York State 1115 Medicaid waiver being examples of policies and practices that our collective efforts have been able to shape. And part of our mission in the coalition is ensuring that communities can access this essential services and resources necessary to address their social and health needs. Our long-standing partnerships with barbershops, hair salons, faith institutions have also been instrumental in improving community health. Our efforts include integrating technology. Here in the picture, you can see the kiosk that we have in barbershops, hair salons, and churches. And we developed these also to address the digital gap and to enhance access to services and resources, offering navigation services and also providing health education on different health topics, mental health, HIV/AIDS, prostate cancer, cardiovascular disease, and making sure that we empower individuals to make informed decisions about their health and their well-being. In regards to the partnerships with healthcare systems and providers, again, it's an honor for us to be sharing this space with the Brooklyn Free Clinic, with Star Clinic, that have been long-standing partnerships with the Institute, and that we continue to create new pathways and new ways of collaboration, right? And exchanging resources. Cross-sectoral partnerships are really essential for building a more trusted, a more inclusive and responsive and accessible healthcare system. And one of the examples of our partnerships include H&H hospitals, federally qualified health centers, citywide. And why these institutions? Because they serve the same communities, the same population we serve. They serve communities regardless of immigration status. So we want to make sure that we align priorities in serving communities and that we co-create strategies to address disparities in health. We also partner with mental health providers or clinicians, the STAR Clinic here, the Brooklyn Free Clinic, in improving access to care and navigation services. So throughout this year, we've been able to invite folks from the STAR Clinic to come to our pop-up events, to our tabling events, to come with us to barbershops and hair salons, interact with community members, answer their questions, do testing at these settings. And with the Brooklyn Free Clinic, I think at the beginning of this year, we established some new pathways for the navigation to services. So for those patients going to the clinic, they have the opportunity to get connected to us so we can address their follow-up with them, give them a call, and understand what they need and get them connected to services and resources. We're excited to continue these efforts. The Brooklyn Free Clinic has also, we understand sometimes the wait line are a challenge for folks, and we've made sure also to include some of our educational material in these spaces for parents and for individuals that are seeking care. And now lastly, our internship program that we have every summer, every fall, we engage students across the health sciences in community-based and participatory research, in community engagement practices. We've had students, even from the emergency department, Downstate, Kings County. We also have public health summer program. So if anybody in this call is also interested in our summer programs or internship programs, please feel free to reach out. So these are some examples of our interventions. And if you ask like, okay, so is it solved? Does the problem doesn't exist anymore? The challenges are addressed? And the answer, of course, is not. The challenges are still here. But community engagement and the work we do and the framework from that Humberto introduced at the beginning that we work from is a vital approach to addressing immigrants' health, right? It is inclusive of communities. It's inclusive of their experiences, of their culture, of their language. And when there is representation, then interventions are tailored to the needs of the communities as their voices are reflected in any effort. This can be research, this can be service delivery, this can be education, this can be advocacy. But representation is really key when designing interventions. And lastly, kind of from on future directions addressing health disparities demands very intentional care coordination across sectors. I think even sometimes within SUNY Downstate, that the Institute, for those that don't know, we are here in Downstate, and we sometimes find ourselves even doing the work in silos, and fragmented care contributes to poor health outcomes. So we really want to name intentional care coordination across sectors as a practice to address immigrants' health. I'll pass it to Humberto if you want to also close us out.
Thanks, Camila. If we want to just summarize, I think that most of you probably have heard some of this data and perspective. I consider myself an activist, a Pan-African activist. And I think I say that to say that when you work with as an immigrant, and the first thing is to, if people really believe you see them, do you see them? Because I do a lot of work in communities and work with the health system. I think we design a lot of stuff without questioning three things. One, does the structure that we create provide the necessary safe space and understanding of who we serve? And so we fit people into a system that really doesn't connect them to what. We did a lot of work with the 1115 waiver, was to do two things. One, reduce the revisiting of emergency room And second, people getting admitted after the discharge. And when you did that work and talked to community, you realize the problem of the system, the structure, the assumptions. So what we provide is to try to do collaboration that we can respond to community as we design care. And I really think is an issue of understanding when we use the concept of culture and the otherness of people, that we run in risks of accepting those otherness. I think that's one of the first. I've trained a lot of the do cultural competence with a lot of downstate medical students. And I know the model that we had before was to bring immigrants to tell them what they like to eat, or this is a total distortion of what culture is, without understanding the people that we train in. Do they understand the community that they're going to serve? Do they understand what identity means in relation to sexual orientation or religious practice of voodoo or santeria? Those things that we have prejudice about. Do we understand what that means? Because you don't treat someone well if you don't think that they're respectful or they're equal, if you have concept of otherness of their humanity. So I just want to end there, because I think a lot of things are designed, how you apply it, how you implement it, depend. Do you see this issue like as a human rights issue in a moment? And I end with this, in a moment where we have a lot of policies to impact negatively the population that historically been discriminated. And in that environment, it requires that we have been more activists in how we provide care and protect the rights of all of us to have access to health care. So we continue to, and we're happy to be invited to this group to continue to collaborate, to start shaping new strategy and understanding of what it means to provide quality health care from a human rights perspective. Thank you.
Thank you. Thank you very, very, very much.